Hey, okay, so hopefully, right, tomorrow, if everything goes as planned, and BT Dubs, I was looking for my stylist to do my awesome little drawings that nobody can ever actually know what they are ever, but I can't find it. So that's kind of unfortunate. All right. But tomorrow, hopefully, if we can get everything lined up, tomorrow in class, we're actually going to work on some splitting and casting. It's going to be super fun. It'll be good times. So before we get into everything for today, all right, we're going to talk about just some fundamentals of rehabilitation for the wrist, hand, and fingers. Before we do that, though, let's actually review from yesterday. Okay, so we went over a lot of special tests yesterday for the wrist and hand. And I actually also realized, and I'll go over this in a second, I need to make one small correction, and it's not a huge one. It is a tiny one in the grand scheme of things. And so I apologize for that in advance, but it's not a huge deal at the end of the day. Sorry to my dog and his ball and his disruptiveness. Okay. So, okay, special tests. Who can tell me and who remembers exactly, generally speaking, right? We talked about how the wrist itself is generally more unstable in which direction? Who can tell me?
Flexion. Wait, extension.
Extension, generally more stable in flexion. So there is one exception to that, right? Who remembers what that one exception is? Injury to what ligament? The wrist generally becomes more unstable in flexion, generally with regard to which ligament?
Is it the SL ligament?
Yes, very good. Excellent job. Okay. Now, however, though, who can tell me and show me, by the way, what are the tests that we would typically do for carpal tunnel? Who can demonstrate this for me? What are those called, by the way? Who can tell me what they're called? Emma, I think you're trying to talk maybe, but you're muted.
Oh, I was going to, and then I changed my mind. But phalans and reverse phalans.
Very good.
Tenels.
Okay. So so for phalans and reverse phalans, Emma, what is a positive test?
Pain.
Pain, and also what? Also what? Reproduction of neurological symptoms into the hand and fingers, right? With phalans and reverse phalans. Painful, potentially also numbness, tingling, reproduced. Okay. All right. Who can tell me? All right, nice job there. Who can tell me what's the name of the canal of the canal through which the ulnar nerve passes between the radius and ulna? Named after a French dude.
The Canal of Guion.
Yeah, there you go. The Canal of Guion. Very good. Heck yeah, nice job. Nice job. Okay, cool deal. All right, more special tests. What test would I utilize to test the stability of DRUJ? What's it called? What was that, Annika? I just saw your mouth move. I didn't hear you talk though.
The shuck test.
The what?
The shuck test.
There you go. The shuck test. How do we do said shuck test? Okay.
When you're feeling for the laxity between the two joints.
Yep. One hand on the radius, one hand on the ulnar. We're going to translate back and forth. Feeling for that laxity. Okay, very good. What about everybody's favorite? Okay, scapular dissociation, right? What test am I going to use for that? Watson's test. I just saw Bella say Watson's. Okay, how do you do Watson's test? If I could talk, how do you do Watson's test?
You put your thumb on the scaphoid and you push.
Okay, what are we feeling for?
If it moves.
I just hit my knee on the table and it kind of hurt. But I'm sorry, I missed that. Say that again. What are we feeling for?
If it moves or there's laxity with it.
Okay, laxity movement, right? Okay, all right. Okay, very good. Tell me a little bit about the TFCC. Where does the TFCC live? Kylie, you're pointing. I know you know this. What is it?
It's like kind of like by the pisiform.
Okay, so yeah, lateral wrist. Okay, very good. Now, here's the deal. Okay, Kylie, generally speaking, how is that TFCC loaded? In what direction is it typically loaded and or injured? Usually, with what direction?
Um. Oh, isn't this the one when like pitchers have that problem a lot? Where it's
Okay,
like,
so ultimately, remember though, right? So any overhead athletes can, right? Definitely because they're in ulnar deviation and compression a lot, right? But mainly, what's another way that these are typically injured? The TFCC is typically injured, typically via a foosh, right? But remember that compression and rotation. Remember I told you guys, whoa, what just happened? Did we just lose the meeting? Oh, sorry, my screen just went nuts and I didn't know what was going on. So I'm going to put you guys can see my hand here, okay, on my table. Remember, right, compression and rotation. Okay, typically compression and rotation is going to really irritate this type of injury. Okay, so remember that. That was me attempting to demonstrate. Yes, I know that was probably fairly poorly executed. However, doing the best I can here. All right. Okay, cool. Guys, nice job. Oh, BT dubs, last review question. Okay. Who can tell me what tendon lives in close proximity to the TFCC? Like literally right next to it. What is that? Oh, Kylie, you're talking maybe?
oh, I forgot to mute myself. Sorry.
Okay. What's the name of that tendon though? Who knows? Well, Bella, if you're talking, I can't hear you.
Of what tendon? I wasn't listening. I'm sorry.
Okay. So the tendon, right, that lives at the lateral wrist, right, literally right next to the TFCC. Okay. What's it called? What's it called? Okay. The ECU. Okay. Extensor carpi ulnaris. Write that one down. Okay. Write that one down. All right. Sweet. Okay. Okay, guys. So one small correction, right? And then this is on me. I misspoke in class, but I'm correcting it now. So really quickly, remember how we talked about checking the flexor tendons at the fingers? Okay. Okay, we still have two, FDP and FDS. But remember, okay, actually, FDS comes up to the PIP. FDP is actually to the DIP. So if you need to make that correction, go ahead and write that down. Do that now. Okay, FDP comes up to the DIP. So remember, okay, if I'm testing, it looks like, yeah. So if I'm testing FDS here, FDP there. Okay, FDP is here. All right, so FDP, distal phalanx, FDS. Okay, that's on me. So any questions on that? Okay, just make sure you guys make that correction, and that's my fault. So, okay. Are you guys ready to get into some amazing, questionably fun stuff about rehab for the wrist, hand, and fingers? All right. You guys just doggone it. I just like you. Okay. All right. Here we go. First of all, who knows and who can tell me what are the arches of the hand? What are those three arches of the hand? Who remembers those? Excuse me. Don't all shout it out at once.
I know one is longitudinal.
Yes, absolutely, Maddie. So we've got a longitudinal arch. Just like that. Okay, what else do we have?
Don't we have a transverse one?
We
Some-
do. There's two of them. Yep. What are they called? So. Who knows? All right, so if I have my hand here, right, got my longitudinal arch, you can see it. Whee! Okay. I've got my two transverse arches here and here. So this one is what? And this one is what?
Oh, it's proximal and distal.
Bingo. Okay, proximal and distal. So let's actually just type those out. Okay. Let's type those out. All right, so we have our transverse arch. Don't forget. All right, there she is. All right. We have a proximal transverse arch. And then we have a distal transverse arch. Okay, here's another question though, right? Who remembers and who can tell me, pardon me, generally speaking, right? What are these, what type of motion typically happens around the transverse arch? Usually, I mean, it is a combination of all three, but what happens around the transverse arch usually? What type of functional movement of the hand?
Is it flexion?
Okay, flexion. Yeah. So yeah, there's going to be some flexion. There's going to be some abduction. So typically gripping and grasping. Okay, gripping and grasping happens around the transverse arch. Okay. Now there's also obviously a little bit of interplay with the distal transverse arch and the proximal transverse arch, but obviously finger flexion. Okay, distal transverse arch. Okay, and then obviously gripping and things like making a fist. Okay, clenching. Okay, also distal and proximal transverse arch. You know what, guys? Having several moments this morning. I don't know why I wrote transverse arch down here. This should be longitudinal arch. I'm a goofy person. I'm just a goofy individual. All right. That's horrible. I'm going to just redraw that because it bugs me. All right. Son of a bucket. There we go. Oops, crap. All right. Longitudinal arch. And we have our, obviously, this one proximal transverse arches. All right. Okay, cool. All right. Okay, so there's the arches. Now, here's the deal. All right. You have the next thing we're going to talk about. Okay, this is actually something that we need to be aware of. Go lay down. Go lay down. Something that we need to be aware of is something called the bowstring effect. Okay, so check it out, friends. Yeah, this is a kind of a new concept. All right. So if we remember, okay, if we remember, we know, all right, that our fingers, okay, there are fingers, okay, we have a distal phalanx, we have a middle phalanx, craps, we have a proximal phalanx, rather, middle phalanx, and we have a distal phalanx. All right, now, ultimately, when we have a tear in the tendon, okay, so we have our EDP, EDS, FDP, FDS. All right, ultimately, when we have an injury in that tendon, all right, we're going to create, in certain circumstances, what's called a bowstring effect. Okay, bowstring effect. You might say, well, Wade, that's great, but what is a bowstring effect? Well, let me show you. Okay, so a bowstring effect, particularly when we have something like a boutonniere deformity. By the way, when a boutonniere deformity happens, what is that typically an injury associated with? Or how does that happen? Who can tell me? How does a boutonniere deformity happen? I see people getting prepared to answer the question.
There's basically a hole or a tear in the extensor tendon that slips over the bone and causes your finger to dislocate.
Okay. So causes the deformity, right? Causes the deformity with the boutonniere deformity. Now, ultimately, okay, my transverse palmar ligament here, which makes up the floor of the floor of my carpal tunnel here, okay, that the tension there with the rupture in that tendon actually causes a bowstring effect. Okay, and let me actually show you what I mean. Okay, so for example, all right, with something like boutonniere. So with a boutonniere deformity, boop, 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 boop. Oh, crud. That's a really horrible distal phalanx there. We're just going to pretend like. Okay, so here's my tendon. All right. Ultimately, what has happened, here's where my tendon was. Now, okay, with this injury, here's where my tendon is now, right? So it's here, right? Whoa. And you can see, okay, that this tendon, it ultimately kind of looks like a bow, right? Like almost kind of like a bow, for example. All right. So ultimately what happens is the transverse palmar ligament creates a straight line of pull. And when the tendon is disrupted, okay, it causes what's called a bowstring effect. Okay, where the tendon essentially kind of dips down and causes that finger deformity. And it looks like a bow, right? A bow with a string. And I'll actually spell this out. Okay.
Is it also like a bowstring in the way that does it create like more tension with the extensor?
Yes. Yep. All right. So and this is kind of more of a critical thinking question, guys. Okay. Sorry, I know that was kind of a long answer or kind of a long little thingy that I just typed out there. But think about what's happening for a second. Okay. So here's the deal. All right. When the tendon itself slips down, what's the one thing holding the tendon on top of the bone? What are those called?
Pulleys.
Pulleys. Okay. We have A pulleys and we have C pulleys. Okay. Our A pulleys stabilize the tendon, obviously keep it on the bone, right? And allow it to glide right on the finger. The other thing though is that we also have the cruciate pulleys, the C pulleys, which actually also stabilize the tendon on the bone, but also at the same time create stability for the tendon with medial lateral movement as well. Now, here's the thing. All right, with that bowstring effect, when that tendon slips down, okay, the line of pull changes, okay, from here to essentially a diagonal line from here to here. Okay. And that is ultimately, you can see that. So that the line of pull completely changes when the pulley is disrupted. Okay. Creates a diagonal line from the top of the finger to the bottom up towards the wrist. We're not going to get too much more into that, but I want you guys to know what that bowstring effect is. Okay. All right. Okay. Now, guys, let's actually talk now about some of the muscles, okay, that kind of run through the wrist, hand, and fingers. All right, we have two, and let me know when you guys have this, and I'll take it down. You guys are good? Okay. All right. Okay, cool. So let's talk about muscles for a second. Who can tell me what's the difference between extrinsic and intrinsic? Who knows? And just give it a guess. Give it your best guess. This is why I'm asking the question. We're learning.
Well, like, doesn't it basically mean the difference between external and internal? Like in terms of like factors applying to it?
Okay. So yeah, definitely close. You're on the right track, right? So an extrinsic muscle, okay, really, an extrinsic muscle is something that crosses a joint and causes movement, right? So for example, the extrinsic muscles of the hand. So if I look at my fingers and I'm moving my fingers back and forth, okay, the muscles that do this and the muscles that do this, do they originate in my hand, or do they originate actually outside of my hand? Who can tell me which muscle does this, by the way?
Extensor profundus, or
Okay.
no, pollicis,
Yeah,
pollicis.
extensor pollicis. Right, and that's an extrinsic muscle because it originates actually in the forearm, right? An intrinsic muscle, however, is different because it has its origin and its insertion on the hand itself. Okay, so within the hand, all right, or crossing the hand and kind of exerting kind of function on the hand, okay, we have 20 extrinsic muscles. And we have 19 intrinsic muscles. All right, we don't really need to know the names of all of them now. We've gone over some of them, but these are just things that I want you guys to know. All right. Ultimately, a lot of the muscles that control the fingers themselves, these are mainly controlled by extrinsic muscles. Okay, because a lot of these have their origin where? They have their origin in the actual forearm, right towards the elbow. And that's why what we'll see when we're putting a lot of these things into practice, when we're doing rehab for the wrist, hand, and fingers, that we actually also need to include exercises for the elbow and forearm as well. Okay. All right. Here's the other thing. All right. When we're looking at kind of rehab and treatment for the hand, and the reason why we're kind of going into depth here is because it's really important to know why, right? We're establishing the goals that we are with patients, and we're kind of setting the foundation for that. So if you look at your hand, all right, you can see that the dorsal aspect of your hand has very stretchy skin. All right. And arguably, because of the stretchy skin that it has on the top of the hand, there is more room there. Were you doing okay? Is this perplexing? No, your face was fantastic right there. I'm not really sure what was going on, but it was pretty great. Okay. All right. So obviously, we have a lot more room at the dorsal aspect of the hand for swelling to accumulate. Okay. So swelling tends to accumulate more easily and in a larger volume at the dorsal aspect of the hand as opposed to the palmar aspect. Because there is more room, there's actually a lot more tissue extensibility with the skin and fascia at the dorsal aspect of the hand. Okay, I'm gonna go ahead and type this out. All right. Okay, now here's the deal. What's the problem though? Okay, what is the problem with more swelling at the dorsal aspect of the hand? What problems do you think that could create? What kind of issues do you think that we could have there if we have more swelling? I'll let you guys think about that for a second before you answer that question. Okay, so obviously at the hand, okay, with the edema accumulation, what crosses the hand, right? What do we have here?
On the dorsal aspect, it's all extensors.
Okay, so if we have swelling, the swelling tend to limit motion or influence motion. Limits motion, okay. Okay, here's the deal, right? So if we have a limited motion due to swelling at the dorsal aspect of the hand, we're going to have an increased propensity for adhesion of the tendon to the sheath. Okay, we all know by this point, right, that we have a tendon sheath and a tendon that sheath and we have a tendon in the sheath that the tendon glides in. If we have, and by the way, what do you think can happen if we develop tendon adhesions? What do you think might happen there?
And you get less function.
Less function. Okay, so what would that, okay, Bella, you're right. What would that less function look like? What would it look like?
The tendon getting like stuck as it tries to move, so you can't flex or extend very well.
Yes. Okay. Yes, Justine, you're right. Now, if that happens, what's going to happen to motion of the finger? Am I going to potentially lose extension? You're dang right I would. Absolutely. Okay. I would lose extension of a digit if I develop tendon adhesions. Okay. Very good. All right. So that increased swelling, right, has the potential to limit extension of the finger. Okay, due to adhesions. All right, very good. Nice. Okay. Cool deal. Now, obviously, one way that we can actually help manage this, right, is actually utilization of compressive dressings, right? So obviously compression is going to be very important and management of swelling. What's a way that you guys have seen? How many of you guys thus far in your clinical experiences have seen hand injuries managed? What types of things have you guys seen used in edema management thus far for hand injuries?
Basically, all I ever see is compression sleeves.
Okay, yeah. So that's a big one. Okay, excuse me. Use of compression sleeves, use of things like stockinette, those types of things, right? To limit swelling at the hand. Okay, very good. Okay. Other things obviously that can be used, you can, utilize things like, shear light or power flex, those types of things sometimes to limit swelling at the hand. It's extremely important. Okay, so obviously we know that the goal is by limiting swelling, we're limiting tendon adhesions. Okay. Okay. All right. Let me know when you guys have that. Sweetness. Okay. All right. Clear. Okay. Here's the deal, guys. Oftentimes, well, not oftentimes, but really every time, the hand itself is divided into zones. Okay. And this is really used more for surgical purposes. So we're not going to go into a ton of detail here in regards to the zones of the hand. But I just want you guys to have exposure to this and know a little bit about it. All right, so at the hand, all right. Okay, we have 5 flexor zones. Spell flexor. 5 flexor zones, and we have 7 extension zones. All right. So what exactly do those zones look like? Give me just 1 second here and I'll show you guys exactly what I mean. All right. There we go. Where did it go? Where's that article I had? Come on. All right, cool. All right, can you guys see this, by the way? Okay, extensor zones of the hand. Okay, so you guys can see, all right, that each digit, all right, particularly each finger, each small finger has a zone. Okay, 1 through 5. Okay, and we're gonna, and these are the extensor zones. All right. Okay, so the extensor zones are, we're actually going to go ahead and draw this out together. All right. And actually, I'll give you guys a minute to actually go ahead and draw this. So if you want to draw it. Okay. So ultimately what surgeons will do is surgeons will actually break the hand down into zones. All right. To guide them in surgical repair. All right. So obviously we see zone 1 there at the DIP at the junction of the distal and middle phalanx. All right. All right. Zone 2, right at the middle phalanx. Zone 3 between the middle and proximal phalanx. Zone 4, right at literally at the mid substance of the proximal phalanx, and then zone 5, right, which is at the MCP joint, basically. Now, who remembers, by the way, we talked about this in class yesterday. What are these little zones between the fingers called? Who remembers what those are called?
The web spaces.
The web spaces. Okay, very good. Patients that have, and by the way, I know that I'm branching off into a review question real quick. Patients that have skier's thumb or gamekeeper's thumb may usually typically in more severe injuries, we'll have pain at which web space, as well as joint line pain.
The
So how
first.
sorry, who said first? Was that Maddie?
Yeah.
Nice job. Yep, first web space, right here. Okay, excellent. Okay, so we have zone 5, obviously at the MCP, zone 6, okay, at the middle of the hand, at the metacarpals, zone 7 here at the radiocarpal joint. All right, and then once we get down into zone 8, that's actually in the distal forearm. So whenever you guys are good there, then we will flip over to the next one. All right, you guys good there? If you're still drawing, still writing, let me know, and I won't take this down. All right. Okay. Okay, cool. So let's go, actually, let's flip over to the flexor zones. Okay, we have 5 flexor zones. All right, let me pull this guy up. It's a great picture here. Boom, there we go. Okay, zone 1. All right, which extends just down past the DIP to the mid portion of the middle phalanx. Okay, zone 2, right above the palmar crease. Okay, so palmar crease to middle phalanx, zone 2. All right, zone 3, palmar crease to just above the thenar and hypothenar eminences. All right. And then obviously, okay, zone 4 is the thenar eminences down to the carpal tunnel. So hypothenar eminence down to the carpal tunnel. By the way, when I say thenar eminence, what am I referring to? Who can show me when I say thenar eminence? What am I? So I see people holding their hands up. Josh, show me. I can't see your hand, buddy. So thenar eminence is what? Yeah, very good. Thenar eminence is here. Okay. Hypothenar eminence is where? So hypothenar eminence is here. Lateral aspects. If this is thenar, this is hypothenar. Okay, awesome. And then obviously, okay, we have zone 5 from the below the carpal tunnel, right, down to the distal forearm there. Okay. All right, this is how we're going to finish up today, guys. So do you guys, and let me know when you have this, and then I'll take this down. Do you guys remember, okay, do you guys remember how we essentially, when we talked about the shoulder, okay, we had very specific goals in a very specific order that we had to accomplish, right? Do you guys remember those? What were those 4 goals when we were talking about the shoulder? I know I'm asking you a question from way back, but it applies to this because we're going to list out very similar goals for the hand.
Is it restore motion and then the 6 gap and then rotator cuff and then
Yep.
plyometrics?
Okay, good. Yes, that's good. So yes, now we have actually similar goals with the hand, things that we have to keep in mind and prioritize. I'm going to take this down if you guys have it. Okay. All right, cool. Here we go. This is how we're going to finish up for this morning. Okay, what are our priorities for the hand? We're going to actually start putting these into practice in the coming days. All right, but we're going to list these out. All right, here we go. Okay, number 1, okay, as they apply. All right. Protection. Reduction of swelling. Prevention of adhesions. Restoration of motion. Okay. Intrinsic strength. Extrinsic strength. And then lastly, functional strength. Okay, so let me guys give you a minute to get those down. Well, let's just kind of go over these one by one here. All right. So protection, okay. Why do you think, okay, particularly with wrist and hand injuries, okay, and especially finger injuries, why is protection so important, right? And really the question I'm asking is, what devices do we typically use with finger injuries to facilitate protection?
Like splints and braces.
Okay, splints and braces. Yeah, for sure. Now, ultimately, depending on the injury, and we'll get into this more later on in the week, but depending on the injury, right? Generally speaking, we're going to have to splint our patients with finger injuries for anywhere from 2 to 3, all the way up to 8 weeks. Okay. For example, okay, a mallet finger should be splinted in full extension for a total of 8 weeks. Okay, which sounds like a lot of time, but a mallet finger should be splinted in full extension for a total of 8 weeks. All right. And, additionally, we could see how in that, maybe in addition to that sling or that splint rather, okay, we can also utilize things like stockinette and other types of things for reduction of swelling. All right. So then we obviously work on swelling, and that actually leads right into prevention of adhesions. All right. So if we limit swelling, we're maximizing the ability of the tendon to glide inside of the sheath and preventing adhesions. Right. So we then begin to work on obviously restoring motion in a systematic fashion, focusing obviously on both the superficial and profundus tendons of the hand and of the finger, right, and of the hand, right, by starting off with slow glides, moving more towards active range of motion. All right. Then we're going to work on intrinsic strength. So strength of the hand muscles, particularly the ones that spread the fingers, right? Those are my hand intrinsics. You can see that when I spread my fingers, my forearm doesn't necessarily fire, right? All of those muscles are located in the hand. Okay. So intrinsic strength and then extrinsic strength. Okay. It's extrinsic strength is regained by movement at the hand and wrist and elbow. Okay. Does that make sense? All right. And then last but not least, obviously, functional strength. What do you think I mean when I say functional strength?
Like practicing picking up stuff and like gripping,
Yep, grasping, gripping,
and like
lifting.
stuff
Absolutely.
with their sport too.
Yes, perfect, Maddie. Yep, absolutely correct. Okay, awesome sauce. So these are the priorities, and these are the goals that we're going to work in as we continue to talk about treating these injuries. Okay. Any questions? Okay. All right, guys. Super proud of you. Next up is my favorite class, JK. And then I'm sorry, I shouldn't say that in front of you guys. I just feel okay. Well, you guys have a great day. You guys are doing awesome. Okay. And I'll see you guys tomorrow. If everything goes as planned, we're going to be doing some casting and splitting tomorrow. It's going to be the bee's knees. Okay. Super excited about it. Okay. Have a good day. If you guys need anything, let me know.
Thank you.
Bye, guys. Yeah, you have a
I
question?
did have a quick question because last week you had recorded the lectures, but I didn't take notes on them during class. And so I just would appreciate if they got posted just because I started.
I'm sorry. Yes.
You're good. You're
No,
good.
I
It's
will
fine.
post them. I'm so sorry.
I left room in my notes for them. So you're
Oh.
fine. But I
Oh,
I started doing something and then I got behind and then I didn't want to start again in the middle
Oh,
of it.
I'm so
So
sorry. Yes, I will get
You're
those
good.
posted for you ASAP. Okay, that's my fault. Sorry about
you're
that.
good.
Okay,
Thank you.
I got you covered. I'll see you in a minute. Okay.